Then we'll come on to prevention, then we'll talk about the treatment, and then we'll talk about a little bit of the patient support things and the recent advances as well. So talking about correct diagnosis, I think if your mind is not thinking about it, you don't see it and you don't do anything at all. And this is, I'm pleased, over the last 20 years, I've been able to raise the awareness of cystic fibrosis amongst the medical fraternity, medical colleagues. So wherever I go, I take the opportunity to talk about cystic fibrosis. We've got our WhatsApp group as well for patients and the other people as well. We've got Facebook as well for people to dig in. And I've got a few people who actually contact me through Facebook to say, oh, we saw this, our child's just been diagnosed as well. So the awareness is rising. It's not there yet, but it is. And maybe a few years ago, Dr. Hina was the only one who perhaps is talking about cystic fibrosis, but now they're multiplied. So all of you can take this message home, cascade it to your colleagues, to your other friends, so that everybody knows about it. And it is wrong, it's other things. I think there may be histological issues, there may be diagnostic issues, maybe other problems, or maybe there's a congenital atresia, intestinal atresia, duodenal atresia, whatever, different source, and they get missed. But Meconium alias, generally in the West, about 15% of the population, and this 15% is the actual last year's registry from the UK data as well. 15.9% of the people were diagnosed with Meconium alias. So once anybody presents with Meconium alias in the UK, we say they got cystic fibrosis unless proven otherwise. So that is your diagnosis gone, but you need to be obviously thinking about it. If you don't think CFA cause of Meconium alias, you're going to miss it. The other bit is the newborn screening, which has become regular thing since 2007 in the UK. And we have all the babies screened within the first 7 days of birth, just like the Guthrie test you may have heard about for hypothyroidism and phenylketonuria and all the other things. So we tend to screen those, although cystic fibrosis doesn't fall into that category, but we now screen, it has been screened for the last 17 years. So we pick up quite a lot of, about 3/4 of the patients. This is a screening test based on the diagnostic test on the screening for that. And that picks about 75% of the cases. That means 1/4 of the patients still present clinically at a later age, and therefore we need to know what the presentation may be afterwards as well. So I think it's still important to know what the other presentations are. And cystic fibrosis is a multi-organ disease. So it affects from head to toes, almost every single organ. As I said, 3/4 are diagnosed by neonatal screening, but there are the others, and for those we need to know what the symptoms are. And this is just sort of summary of the major organs involved. Obviously lungs and intestines are the most commonly. Then you got liver, and through medicines you may get complications involving kidneys, etc. as well, metabolic diseases, infertility, hyperbilirubinemia in the neonatal period. All those things happen. So you need to be aware of the presentation of those conditions before you can then start thinking about doing the diagnostics. So clinical, these are the common things that we come across in the UK. So Meconium alias, recurrent respiratory tract infections, nasal polyps, and failure to thrive. And failure to thrive and respiratory problems, usually they both account for about 70% of the presentations, but you've got 15% as Meconium alias, and then the others are less rare. But whenever somebody say even have rectal prolapse in the UK, we say we've got to exclude cystic fibrosis, although there may be other reasons, but that is one of the things that we always consider. And then the electrolyte disturbances, which got, I think they became to like 1948, when there was diarrheal diseases going on, and CF patients ended up with the electrolyte imbalance, and that's where they found out, oh, there's a sodium issue. And 10 years later, 1959, sweat test became the basis of the diagnosis as well. So these things happened over the years, so they didn't happen overnight. And this is just to compare the incidences of the presentation in Pakistan. So this is only based on about 22 patients. But you can look at the recurrent pneumonias, 77%, and at the bottom, failure to thrive, 72%. So all those things happen regularly. But what happens in Pakistan, the diarrheal disease, this is one of the gold standards. And I just want to highlight what has been happening in Pakistan. So this is one of the papers from Aga Khan, Karachi, talking about sweat test as a diagnostic test. And just wanted to mention those numbers because same institution is telling you different things, 50, 80, and this is I think from Northern, this is from Rawalpindi, publication from Rawalpindi. 80, Lahore Children's Hospital, cut-off point 90. So we really, this is the standard, UK and USA. In the first 6 months, it's slightly lower, and then in the older age group, 6 months plus, it's slightly higher. But the cut-off point is not 60, whatever. We standardize it, we agree on it, and there should be some standardization. And we need to review that regularly as a quality control measure to make sure that we actually diagnosing these patients properly. So that is the one sweat test. After sweat test, genotyping, and genotyping become quite important nowadays. And I think I don't need to mention, you probably know this is an autosomal recessive condition. And autosomal recessive, we knew it from early 40s based on the family studies, because you know the way it ran in the family, it was predicted to be an autosomal thing. And then later in 1980s, it was located on chromosome 7, the long arm from chromosome 7, and then 1987 or thereabout, they found the CFTR gene, which is responsible for cystic fibrosis. So it is only those 3 small amino acids that were deleted from the DNA that subsequently did not replicate the protein properly, and the CFTR for CF disease, it controls the chloride channel at the surface epithelium of various organs. And in the absence of that, you don't get the chloride and you don't get the sodium movement with it, and you get the problems with that. So that is the issue with that. And at the moment, there are over 2,120, that's actually not over, that's exactly the figure, I think 24 hours ago when I was updating that number. So that's the number of CF mutations that we have. And some of the papers underneath, there are 2 papers from here, and I'm pleased through the work of the local colleagues, we got 2 PhD candidates, one from Aga Khan and one from Lahore, who are doing PhD on the genetics of cystic fibrosis in Pakistan. And we've been able to dig into their research project and offer that service, genetic testing, to our CF patients free of charge as well. Now we're dealing with other companies as well, charities, to give wider spectrum of those 2,121 mutations. Most of those, we're trying to cover that as a free service across the country. I think we'll have some genetics person doing bloods today as well. Those families who had bloods taken already or want to have it done it again, what we're doing is we're trying to get these bloods registered with Indus Hospital in Karachi, because we are working with some charity organization to get the new medicine that I'll talk about towards the end, which costs about 3 crore per person per year for life, which nobody is able to afford on the halal earnings in Pakistan. So we're trying to get that free of charge for these patients, and we're trying to get the genotypes done because it is dependent on genetic makeup, what they are. So those people who will be out there with having some blood tests on those as well. So until a few years ago, Delta 508 was the only mutation that was being tested, but this is not as common as the rest of the mutations in Pakistan. It's expensive. I think nowadays this Delta, I think it's probably 78,000 rupees. So it's not that expensive nowadays, but it's still £8,000 is quite a lot of money for somebody, especially if it turns out to be negative and you don't get anywhere at all. If it's a positive, it's useful. It's negative, they probably got other mutations, but they wasted the 8,000 rupees. So genetics, the benefits of doing genetics is one, obviously, if the sweat test is failed, which it does happen many times, then we can get genetic testing. It's also used for prenatal diagnosis, and this is CVS service offered to pregnant ladies if they wish to go ahead with the test and choose to have abortion should the baby be affected. So lots of ifs in there, lots of personal preferences, lot of religious thoughts on that one, and that is people's, their personal things. I give the information and choice is theirs, but the option is there which can be utilized. And then obviously, just like thalassemia, I think people are advised to have thalassemia test before marriage. Is that right? That's a law, I think, although not many people abide by that. And you're looking surprised. It is law, I think, in Pakistan to have thalassemia before you get married. Screening for CF is another option for families where there is a child with CF. So if there's a cousin marriage or somebody within family, they can at least have that tested if they know their mutations, and then they can still get married if they want to, but information there. Decision is there, but at least there is that sort of extra information they can utilize. So talking about, coming on to prevention, how can we prevent cystic fibrosis? And that can happen at various stages of primary prevention, secondary prevention, and tertiary prevention. And if we go through it, primary prevention is where you know there's a family with cystic fibrosis. I know one of the pediatricians here, when they used to see, not in Faisalabad, somewhere else, I won't name the place, that if they've diagnosed somebody with cystic fibrosis, it wasn't preventing it, they basically say, forget about this child, go have another one. And that was the general advice given to the families. And it's a very unethical, unacceptable, painful piece of advice to any family. Rather than doing something about the child they've got in front of them, just saying forget that child. How can parents forget their child? They can't see the suffering of their child, and you can't guarantee the next child is going to be CF or not. So you may produce, and I've got family with 2 or 3 children in Pakistan. There's families here in Faisalabad with more than 1 child. So having another child is not a guarantee that you're going to have a child without CF. 25% chance is that you will have CF, 75% chance that it's likely to be normal. But that is not the way. And this is the way I feel, if you come across something, try to do something about the condition. Don't ignore it. Don't sort of put it under the carpet. Just deal with the problems, educate the families, and tell them what to do rather than to go have another baby when they may have another CF family. So that is the prenatal diagnosis, and then of course genetics for the affected families. Secondary prevention that's very important. That is where we want to prevent the problems that we see in cystic fibrosis, or anticipate. And I put that modulator medication right on the top. So it's not what we call cure. So it's not a tablet or injection that will cure the cystic fibrosis. It's a lifelong treatment. It's oral medicine. It's twice a day medicine. It's some of the medicines or the mutations you can give it from 1 month of age, and that basically corrects that CFTR defect, that chloride channel. And with that, the sweat test also reverts back to normal or improves. And we've actually been doing the sweat test on these people who are on modulator treatments. And we can then also tell who's not taking the medicine. And just 2 weeks before I came here, to do the CF clinic, there was one 14-year-old young girl who's been on this treatment for 4 years. And her sweat test originally was quantitative, 95, diagnostic, corrected to 19 on the treatment. And just before the clinic, she had sweat test and was 57. Just proving that she was not taking the medicine, and therefore the things are creeping back up again. And not taking the medicine is a big issue. Not being able to afford, not being available, not taking when it's available and affordable, those are the 3 major things that also leads to the failure of treatment for any condition as well. So modulator treatments, I take it as a prevention. So if you give it, you can prevent. They don't need as much enzyme replacement, they don't get infections as much, their growth is good, and they don't get all the other issues with CF, diabetes, etc., and all those things as well. So modulator treatments. And then maintaining the nutrition is important, and I think almost everybody in Pakistan is malnourished if they got CF. So their BMI, and I said you need to do this. He said, yes, it's a sunnah to do it. I said, mashallah, you get more swab. The niyyah of sunnah, it's a swab for that, as well as du'as from your wife and goodness for your child as well. So you're doing 3 good things in that act. So please ask your families, ask the fathers. If it's no father, he's got to go to work, that's fine. There are extended family things. Get other people, other members, the grandma, the father, the uncle, the pupi, the amasi, hala, whoever it is. Get them involved in the care. Don't just leave it to one poor mum who's got lots of other things to do as well. And then coming on to tertiary prevention, and this is the prevention of the likely complication of the disease. Okay, and this is through regular monitoring. We know nutritional status. So, for example, if somebody's got poor nutritional status and they need lung transplant, they won't have it because they're not going to do very well. We know that vitamin deficiencies occur, fat-soluble vitamins A, D, E, K. So we do want to give them so they don't have the rickets, for example, they don't have the other deficiencies. The lung function we monitor regularly because that is the only way to see if they are doing well or not with recurrent chest infections and